Thanks, Tad. So I'm going to give a lecture on the correction of extra-articular deformity. I say that, but I think, honestly, significant extra-articular deformities are quite rare in North America. You may, in fact, face them more here, post-traumatic. It's relatively uncommon that we would see significant ones in our practice. The ones I've seen have tended to be secondary to malunited fractures, such as demonstrated there, previous osteotomies that aren't quite aligned correctly, or some metabolic bone disease, and Paget's is fairly endemic in southwestern Ontario. So with the extra-articular deformities that you see in your practice, you have three choices on how to deal with those. You can perform an interarticular bone resection and soft tissue balancing, so in other words, a more standard or typical total knee arthroplasty with appropriate releases. You may have to include an osteotomy at the time of your total knee arthroplasty, and I'll touch on that. Or lastly is a stage corrective osteotomy followed by a total knee after it's healed. So those are how I think about as the three possibilities of what I may do in my practice, and I'll try and take you through my thought process on when to do which. Again, we're trying to achieve correct alignment in these knees. We've already heard about that. We're used to thinking of the distal femoral resection in terms of a 5 to 7 degree valgus to the anatomic axis, and I think alternatively, the distal femur resection is, as we know, 90 degrees to the mechanical axis. Tibial resection, of course, is 90 degrees to the long axis. So let's take you through the most, I guess, common scenario is an interarticular bone resection and then soft tissue balancing. So it isn't profoundly complicated. When you're planning for these cases and you're dealing with an extra-articular deformity, you plan the resection and then look to see where does your resection come out. So you've dropped that plumb line from the center of the head, center of the knee, 90 degree angle, and where's your cut going to be? And if your cut is going to be not violating the insertion or the origin of the collateral ligament, then you're going to be able to perform that correction through your knee resection. If, on the other hand, you plan it out and the correction is above, in other words, you're going to be compromising the insertion of the collateral, the origin of the collateral ligament, then it's a little different story because you're not going to be able to do that at the time of the OR and that correction. So let's go through that. So this is what I call the Canadian navigation system. I don't have navigation in my hospital, so I bring fluoroscopy in at the beginning of the case. I fluoro the center of the femoral head, and I put an ECG, in fact, stack them and put two ECG leads so I can palpate the center of the femoral head. Is that as accurate as navigation? Probably not. But I'm going to be using extramedullary alignment in these cases because I can't get an alignment rod up, and I need some way to reference the femur if I don't have navigation. So this is the way that we've done it in our place for years. At that point, then you use a dedicated extramedullary alignment guide. You palpate the center of the head. You can do it through the dressings from where the ECG lead is, and then that's where you're going to gun sight your alignment rod to that. And I agree with Amar. I mean, these cases are complicated enough. I do standard as a PS knee, but if you do back and forth, I say these cases plan for a PS knee. It will simplify the process. So here's a case example. It's actually the first one I inherited in practice. So this was done in '96. This preoperative deformity presented, post-traumatic, previous fracture. The alignment, you can see it's mal-aligned, but by the same token, drawing out the lines, I felt preoperatively, I could do an intra-resection within the knee. Didn't have to do an extramedullary resection. That's the knee, and it may look a little odd, but that knee is now, the last follow-up was 2 years ago, so it's now 12 years out, and I think doing reasonably well with no significant wear. So that's achievable, and I think with all the techniques you've heard before me, and I won't reiterate all of those. So when can you do this technique? Generally applicable when the varus valgus deformity is less than 20 degrees in the femur, or even up to 30 degrees in the tibia. Flexion extension rotate, about 25 degrees. What's not well assessed, as we all know radiographically, is internal-external rotation deformities that can also be coexistent with the other deformities. You can't really assess those radiographically unless you get a preoperative CT scan. The principle being that the greater the deformity and closer to the joint line, of course, that's going to have an increased impact and make it even more complicated for you at the time of surgery. If the deformity is greater than 20 degrees and it's right in the supracollar region, those are the ones, and they're not that uncommon, where resection and soft tissue balancing may be more difficult. But again, you map it out, you map out your lines, and that'll guide you. So what about a corrective osteotomy? Well, obviously the indications are when it's a more severe deformity, perhaps over the 20 or 30 degrees, spanning femur tibia. The goals of alignment are unchanged in these cases. At that point, if you're doing it at the time of your total knee, you have to bypass, obviously, the osteotomy, and so bypass with stem components. That's our goal. So here's another case. We draw this out. In this case, felt that it was going to be compromising the stability of the knee to try and do it all through the knee, and performed a corrective osteotomy at the time and stemmed it. And I think, again, this is an 8-year follow-up, and this patient has done well. So those are sort of the easier ones. The more challenging ones is when they're more significant remote site. And I think, in all honesty, historically what we've talked about is really trying to do simultaneous osteotomies in a total knee. And while I think that's certainly how I trained, I've changed my thinking a little bit, having seen a number of these either get into non-unions or malunions or problems with healing. And so if it's close to the joint, fair enough. But if you're going to have to do a custom stem or stem extension, I'm not so sure it's actually better to do the osteotomy first, get it to heal, and then go ahead and do your total knee. I think it might be a little bit much, and this is one of the ones that I did in my practice that actually had a delayed union. I had to go back in and bone graft it, and I tried to do it all at the one stage. So, in conclusion, I think we need to define the deformity, determine whether or not we're going to be able to do an intra-articular plus total knee, osteotomy and total knee, or remote osteotomy, and achieve the alignment goals that you've already heard about this morning. Thank you.